I think it's the bone joints that's really interesting. It's interesting that we're good at things they afterwards, so our territory, being a new mum bit, actually shopping and I think before that, especially in anaesthetics, there's lots of really good things for treatment.
But there are some changes.
Okay, so you have stepped up to the mark and bombarded me with post-it notes, so that is greatly appreciated. I'm still sifting my way through them. And there is some sense in what's going on over here. I know what's happening. I'm going to tell you what I've got up, and I appreciate that it might not have captured everything at the moment, so if there are things at the end of this that you think, I just need to make sure that you definitely got that in there, come and talk to me, but I am still working on it. But as a sense of what's been going on, wow. Okay, so we've got stuff around communication, no surprise. Stuff around communication that is, there's things around notes and how information is communicated. So it might be that there's stuff around using symbols like emojicons on the front of notes so that you get a sense of whether or not this is something that is going to be sensitive or not, was my interpretation of it, but tell me if I'm wrong. Using much more visual so diagrams and pictures in the notes will also be helpful, and that will help people who don't use English as their first language. So that using ways of communicating, so the use of baby diaries or the use of sharing information. If mum's not present, maybe the mother's very ill and the baby is in the neonatal unit, or the baby's okay but the mum's not well, but they're separated for whatever reason. There's something about knowing what's happening and knowing that good care is being taken of both mum and of baby. So it's interesting because there was something about, it'd be really great to be able to have photos and you hear what's going on, but as a mum actually I want to create my own memories. I don't want to have a second-hand shot of what this was like. I really need to be able to, so there's something about making that contact possible so that mums are able to build their own memories of babies, and that might be through Skype and that remote kind of work, but it might be that opportunity to go and visit and hold and take care of the baby is really important. So I've got all of that kind of stuff under communication, but there was other things as well in terms of not needing to keep repeating the story, so communication and links from the hospital to community links, but also to other parts, to other hospitals if there are transfers. So that communication was really important, and only needing to have to tell your story once and not have to keep going over it. There's quite a lot in here around all staff having really good communication skills. So not just the staff that are there that are present on wards, but reception staff and staff that are working in the back office that may have contact with women or partners after birth or after a trauma has been experienced or a bereavement. So there's something about the compassion that goes along with that communication, and that there needs to be some really empowering conversations, that women need to feel that they're able to cope with the situation that they're in. And then there was other stuff around communication, so you can see how broad this communication thing was. There was other stuff around the communication of overhearing conversations on the ward and what that can happen in terms of raising people's anxieties. So if you hear difficult conversations or you begin to hear about experiences that women have had that have been quite traumatic, then that can raise anxieties. There's something about being able to manage that as well. Not surprisingly, there was quite a bit of stuff in here about the language. So I've invented my own acronym, which is a TAA, a TAA, which is terminology, acronyms and abbreviations. We don't like them. we need less of them. So stuff around the use of incompetent cervix. This one was a good one that I liked. So have you ever heard a woman say, "I'm expecting a fetus"? In terms of terminology, so that'll get up there. So really being respectful of the woman, that you're moving a woman, possibly if there's going to be a transfer, that you're moving a woman, not a thing, so not an object, and so treating them with respect. Difficulties that, if there has been a very difficult birth and there is a separation at that point, that stuff around bonding or taking care of the baby might be just really difficult at that time. And so there's something about whose baby is this, and the relationship between nursing staff and the mother. Obviously wanting to be able to offer choice and encourage women to be able to take care of their baby, but actually sometimes there's some compassion that's needed, that today's not a good day and I just can't do it today. I understand that I need to bond with my baby, but this isn't a good time, or I understand that I need to be feeding, but I can't do that just now. And so all of the emotions that go along with that is not about being a difficult patient, but just that it's not working for me just now, and all of the guilt that can go with that for that mother. So a real cry for the need for empathy, there are a number of really strong quotes that came out. So one post-it said, "Having a baby on the neonatal unit can be like going through a mincer." So the need for empathy and support, and maybe there aren't any words that are needed, but just being there and being empathetic and compassionate in the moment is what's required. There was quite a bit of stuff around infection control and the anxieties that can come out of not knowing whether or not the same rules are being applied in different places. So if you've been transferred to a different ward or to a different hospital, or you've been transferred out of area, or that there can be some differences in practice. And that can raise anxieties again for new parents, mothers and partners. Concerned about, this was how it was working here and now there are a different set of rules here. So a real cry for there to be some kind of consistency and maybe some networking across hospitals and across areas. And that the rules are consistent and that they're evidence-based. Transferring, there was some stuff in here about just we need to actually look and see what good practice is out there. What can we learn from other places? So an example that we could learn from stuff that might be happening in the Midlands, or that there might be stuff in Sydney that's good practice that we could learn from. So really seeking out good practice and having your radar open to thinking about how can we support women that maybe need to be transferred to a different place. So continuity comes in there, and continuity, inevitably stuff around continuity and continuity of midwife, continuity of consultant, continuity of the support that's available. So needing, a really individualised response to supporting women, and that might be around having an advocate that can speak up for you and fight your corner. But also that encourages the woman to be able to take ownership. So stuff needing to be really person-centred and focused around the individual and their family, their partner and the baby. So that might be around appointments being booked. So I'm now kind of moving into stuff around aftercare. So some women feeling that they've been discharged into a void and then they have nothing. So it's like a big loop. If this could be kind of curled round in a coil, we're coming back to the need for really good communication in aftercare and the support that needs to be there in terms of bereavement and trauma, having the opportunity to be able to debrief. And maybe, there were some great ideas that were coming out about things that you could do about this. So stuff around, discharged mums still being able to come into the neonatal unit to be able to make that contact, because there's an anxiety there for So this step down, now I don't need as much intensive support, now what's going to happen, can I cope? And something about being able to empower women to feel that they're okay, maybe about those links back into the neonatal unit there. And so again, stuff around the complexity of care, the length of stay in a hospital, whether or not the woman is feeling isolated because they're far away from home and so not being able to join mums and babies groups, or families, and getting the support that they need from family and friends. And if you're out of area, just some of the practicalities about registering with the GP and the health visitor and how that works, particularly if you're away for a considerable length of time. There's another section in here that's about capacity and the ability to be able to deliver a service. So things around the need for there to be stability in the workforce, and I'm guessing, you know, that's not something that you have control over, but a recognition that to have some stability and some security in terms of the knowing what team you have available to be able to provide care and help. And so just recognising some of the pressures that are there, that there may not be a room available for 4 weeks, or that they've got 200 referrals in a month, or, you know, that kind of stuff around capacity has a real pressure on being able to deliver that service. So that connection between being able to offer medical support and the emotional, the non-clinical support. You know, it might be that we can do the medical stuff, but the non-clinical stuff that's around the support around bereavement and you know, giving time to be able to work through that experience is a real challenge. Okay. Whew. So, and there's loads more. Does that feel like you've got a sense of the conversation? Does that reflect the conversations you've been having around the table? Have I misinterpreted anything? Is there anything that I've not said that you think I need to make sure that that's in there? Like I say, do come and talk to me, because there's lots of other things in there that
I just think about breaking boundaries between clinical bodies in the hospital.
Yeah. So I've got something, tell me if this kind of fits with this. There's something about having a specialist coordinator that liaises not only within the hospital but externally with possibly with community practice and yeah, so that kind of liaison and coordinating it, but there's actually a role that might help break down some of those boundaries if there's that, because it feels like those barriers are around effective communication and not necessarily talking to each other.
I think there's a bit of that also, because I see it sort of from the postnatal ward and a mum going to the neonatal unit. And I've just written a note here that actually I don't know if ever a midwife looking after the lady has told me, I've gone to the neonatal unit and spoken to the nurse looking after. I don't know if it happens, but I've never heard that being said. And so I think there can be communications between the people looking after the mum and baby unit.
Yes, yeah, okay, I should make sure I get that, because I think it fits in with something else that I've got on the post-it note. So thank you. Anything else for anybody else?
Brilliant. Thank you very much, Anna, for that very comprehensive roundup. Thank you, everybody, because that's an amazing lot of information that you packed over there. So I have just slipped onto your tables some sheets that look like this, which are head sheets. So if you can pass them around. And what I want you to have a think about is what you might do individually or what you might do as a little group. Either with people in this room or people outside this room, and jot something down.